All right, well, hello. I'm Dr. Page, as Mike said, and I am a dentist with Oz Family Dentistry here in Mankato. It's been around a long time. The founder was Dr. David Ozdaba. I don't know if any of you know him, but he opened the practice, I think it was in 1956. And then in 1984, his son joined him, and his granddaughter actually joined us a couple of years ago as well, his granddaughter Gretchen. So three generations of Ozdabas in the practice, and I'm the gray duck, so the odd one out, but they have accepted me. And so just a little bit about our practice. That's a picture of our building and our team. We've got 3 doctors currently. We'll have a 4th doctor joining us in about a month, and you can see one of them is devastatingly handsome, and 2 of them are okay. But I'm going to talk a little bit today about just dental care for our teeth as we age, and I'm going to start a little bit just by talking about how our teeth change as we age. And I would say one of the biggest things that happen is that the pulp, what we call the pulp chamber, it's the hollow space within the tooth where the nerves and the blood vessels are. Over time, and especially as teeth have been, maybe treated, had cavities and been filled and been under additional strain, that pulp chamber tends to shrink. It moves away from the outer surface of the tooth and the root, and it also tends to calcify. And this is just an example. And I mean, I guess sometimes I'm surprised by, people don't really have a good picture in their head of what a whole tooth looks like. Like if we extract one and they actually see it with the roots, they're kind of shocked at how large it is. But it has what we call the crown or the coronal portion. That's the part above the gum line that you chew with. And then also the 2 roots that extend down into the bone. Thank you. And what you see on this x-ray here is this is a very young person's tooth. You can actually see these are baby teeth, and there's adult teeth underneath them growing in. This dark space that you see in the center of the crown and then extending down into the roots. And on this tooth, the roots aren't even completely formed. You can see they're open at the bottom. You can see that's just a very, very wide pulp chamber. It's huge, actually. So, if you're doing dental work on a tooth like this, it's very easy. You have to be careful not to breach that. But it's the same reason, maybe a little kid will bite into ice cream, like an ice cream cone with their front teeth, and ooh, it's just terribly sensitive for them, where at my age, I don't feel it. But you can see, too, some examples here of cross-section teeth, so teeth that have been extracted and then cut in half. As they age, that chamber gets narrower and narrower. So one of the important consequences of this is that teeth become, with the loss of that pulp chamber and some of that vitality and the pressure of the fluid and the blood tissue in there, they become more brittle. They also become less sensitive to damage, and that means things like decays, cracks, cavity. They can progress to quite an advanced point before a patient might be aware that there's even a problem. And as an example of that, this is something we see fairly frequently. And I'm sorry if any of you are don't like gross images, but I'm used to it, so may have poor judgment of what I should be showing or not. So this is a tooth that's just broken off essentially at the gum line, and it kind of looks gunky and it's decayed. If that happened to a 22-year-old, they would be in agony. They'd be come in, you would see the tooth is bleeding, they would, be up all night. We see very, very often in patients who are maybe 70, 75, especially into their 80s and early 90s, that can happen and they don't even feel anything. So they come in and they say, my tooth's broken. You can see into the center of the tooth there, or sort of the remnant of where that chamber used to be. They don't have any pain at all. They say, I feel sharp to my tongue. That would be the chief complaint. And so, that's just, I put that up there because it's just, the point of that is to be aware that, as we age, you might think, or if you're in the mindset of, I should only go to the dentist, or I should only, make an appointment when my teeth hurt or when I have pain. There's problems that can be getting, very advanced, very out of control, moving into a stage where we had certain options and now we don't in terms of treatment without someone even being aware. Another thing to consider is how the oral environment changes as we age. And by that I mean just kind of the rest of the mouth, the gum tissue, the health of the overall, what we call the oral cavity. And the big one would be dry mouth. So I would say probably the most common complaint or issue we see driving dental problems in the elderly population is dry mouth. And the reason for that is a huge cause of dry mouth. One of the main causes is medication-induced dry mouth. And so there's major salivary glands kind of in the cheek, underneath the tongue and down under the border of the jaw. And about 80% of the most commonly prescribed medications have a side effect of causing dry mouth. And they do this usually by interfering with different receptors or blocking different receptors in saliva glands that molecules and signaling molecules in your body would normally attach to and tell that gland to release saliva. And they block that, or they damage that, or they interfere with that. And so you get drastically reduced saliva flow. Another thing that can cause it is radiation and chemotherapy. So for patients who have had cancer and undergone chemotherapy or radiation, the reason that happens is cancer, just kind of by its nature, involves cells that divide and turn over very rapidly. So they reproduce a lot. They're reproducing out of control. There's various tissues in your body, and certain of them, kind of like the mucosa that lines your mouth, the mucosa that lines your intestines and your digestive tract, and salivary glands also do that. They reproduce very rapidly. They have a high turnover of their cell population. So cancer drugs and chemotherapy and radiation target those cells, those types of cells, more severely than they do cells that don't turn over as much. And that's how you get damage to salivary glands. Absolutely. Yeah. It does, yep. So chemotherapy, typically you're getting infusions. And sorry, just to rephrase the question, it was, does it matter in terms of radiation where you had it? So, if you have it targeted at a specific part of the body that's far away from your mouth, are you at risk? And the answer is much less. So patients who have had head or neck cancer or tongue cancer and are getting radiation directed right at those areas, it can be very, very devastating. And typically before they do that treatment, they'll recommend that patient go to a dentist and just get any potential problem taken care of that could, possibly, be an issue down the road ahead of time, so that you can be more preventative. And with chemotherapy, that's typically, you're getting an infusion that goes system-wide, so it's much less targeted approach, so you have the same problem. But that was a good question, absolutely. And the reason that matters is just that for the health of your teeth, saliva is extremely important. So it looks like water, but it's very, very complicated fluid. And it does a few things. One, just physically, just by its flow, the production, kind of the areas in the mouth where the saliva glands are located, it washes debris away from your teeth. So food debris, plaque, bacteria, things like that. The really, really important thing saliva does is it buffers acid. So the way that decay happens is that when you eat foods, typically with carbohydrates in them, so even complex carbohydrates, but especially simpler carbohydrates and sugars, bacteria in your mouth feed on those, and as a byproduct, they produce acid. So if you were just to sample someone's saliva or their mouth after they ate, there's kind of a huge spike in acidity, and after about 30 minutes, that comes down. And the reason it comes down is because there's buffers, there's chemicals in your saliva that neutralize that acid. So someone who has dry mouth or severely reduced saliva flow, you do that same sampling and they'll eat, a carbohydrate or a sugar, that acid will spike way up and it just stays there. And the come down is much, much more gradual. But it means instead of their teeth being subjected to maybe 30 minutes of an acid attack before things are neutralized and teeth can start to rebuild, maybe that goes on for an hour or 2 hours. It's sort of a related point to that. Even in young people, even in healthy people, even when people, elderly people without dry mouth issues, saliva flow goes way down at night. So we see some of the same patterns of decay in people who have really reduced saliva flow as we do in people who maybe even are brushing, say in the morning or midday, but go to bed without brushing. Because if you eat something before you go to bed and you don't brush and you don't do anything to remove that plaque and that bacteria, you get that same acid spike and you go to sleep, your saliva flow drastically turns down, and so that acid spike just lasts a lot longer than it normally would, say if you eat breakfast and don't brush afterwards. So that's one of the most beneficial things saliva does. It also has direct antimicrobial properties, so it can inhibit harmful and dangerous bacteria that produce the acid that attack teeth. It also contains minerals that rebuild teeth. So it has dissolved calcium in it. Calcium is one of the main components of the mineral portion of your teeth, the stuff that makes it hard. And when they've experienced an acid attack and some of that mineral has dissolved out, when they're bathed in saliva, that mineral gets taken back up and it sort of rebuilds the teeth. That all make sense? Yeah. So consequences of dry mouth. Patients who are suffering from dry mouth become much, much more prone to cavities, decay, and we see decay in places we normally don't see it. So, and again, in a young person or even a healthy elderly person with really good saliva flow, you're usually going to see decay between the teeth, places that are maybe trapping food and it's not getting removed, so bacteria can just keep feeding there and producing more acid. Or you're going to see it in the chewing surfaces where you have deep grooves and pits that are, again, sort of trapping debris and are a good home for bacteria. You almost never see it on the flat, smooth surfaces of teeth like this. You see that kind of pattern of decay typically only in people, A, with real big problems with dry mouth, people who just are snacking a ton and not brushing at night. So that's the kind of thing we see in, 14-year-olds who just got their braces off and, telling their mom and dad they're brushing at night, but they're not. And then we see that and we're like, really? Are you? All right. No, what were you going to say? What? Yeah, so you said it looks like the decay is more around the root, and it's typically, yeah, it's concentrated at the gum line. And one of the reasons for that is that the enamel becomes thinner there. And especially if someone's had some gum recession, so the gums have worn away a bit, then it actually is, the first parts of the root surface that are being exposed. And they're much less resistant to decay. They have less mineral to begin with, so they break down more easy. But yeah, that's true. So people become more prone to cavities. Cavities affect normally resistant areas of the teeth. Cavities advance much more quickly, and restorations are more likely to fail. And the reason for that is in a situation like this, you see these cavities here, but probably all this surrounding tooth structure is pretty badly demineralized itself. And so when I see patients like this, the difficulty of treating those is you start to, use your drill to remove that decay. And when you're using a drill, a slower drill to remove decay, it feels kind of like you're drilling into wax, like candle wax. And if you get to healthy tooth structure, it's usually like you went from candle wax to hitting like hardwood, like walnut or oak. In a situation like this, you get into what looks like the healthy tooth structure, and it still feels like kind of, balsa wood or really hard wax. You never get to that point where it's really like, okay, I feel like I'm back to solid tooth structure. So you wind up trying to finish these fillings on pretty poorly demineralized tooth structure, and there's not a great fix for it. There's not a great solution. So that's why restorations are more likely to fail, and you kind of get in this pattern. And there's things we can do to help with that. One, we have prescription toothpastes that have much, much higher concentrations of fluoride than normal. And the reason fluoride is important, the reason it's in toothpaste is I talked about how your saliva has dissolved minerals in it, particularly calcium. And when tooth structure has been dissolved and then it's bathed in saliva, those minerals get taken back up. Fluoride can replace calcium in that process. And it's much, much, much more effective at kind of getting taken up into the tooth and rebuilding tooth than naturally calcium. So in a situation like this, sometimes we prescribe that there's that high concentration of fluoride in toothpaste. And if people really use it diligently for 3-4 months, they'll come back and all these areas that felt really soft suddenly feel rock hard. And it's easy to kind of take out the decay and get back to solid tooth structure, and that can make a big difference. There's other things we can do to that too that help. You can give prescription medications that increase salivary flow. The only difficulty with that is they're very non-specific, so they just sort of ramp up all the rest and digest processes in your body. So, they can make people feel lethargic. They can kind of make them sweat a lot. They can just have other side effects that are unintended. So, those are not always ideal, but they're an option. Another thing I just want to talk about is how diet changes as we age. And I'm thinking specifically as people reach a point in life maybe where they're more challenged with mobility, more challenged with agility, might not have the energy to be cooking for themselves or someone else is cooking for them. Sometimes that means that they fall back just on foods of convenience that might start to predominate. So, microwave dinners, other things that, and I put up this picture, it looks pretty healthy, and you say, okay, you got turkey, you got stuffing, you got mashed potatoes, you got corn. But a lot of times the sauces or just the components in these, these pre-made foods have tons of added sugar, tons of simple carbohydrates, so that can affect your teeth. Good fuel for cavities. And then there's the question of how life circumstances change as we age too. So people's agility and kind of, as I already mentioned, ability to care for themselves may decline. People who transition into long-term care settings or in nursing homes are often dependent on others for their oral care. And that's just, honestly, in my experience, a very difficult thing. You know, people who are taking care of people in long-term care settings have a lot of responsibilities. Often they're overtaxed, they're overworked. Their ability to, you know, on a daily basis, attend to someone who might have a lot of dental needs and really make sure they're doing a great job of brushing their teeth, flossing, everything, you know, that we would ideally want them to do, you know, it's just difficult to have that get done. So it's a more challenging situation. Also, their ability to access and tolerate dental care may decrease. So people may come, you know, have dental needs, but they come to us and they can only come on certain days when they can get a ride. It's very difficult for them to transfer from the chair, their maybe wheelchair, to our chair. Sometimes they can't even do that, and you have to work on them sitting upright, and they might not be able to tolerate long appointments. There might be difficulty with swallowing or gagging, and it just makes it more difficult to get the dental care they need. So the question is, what do we do about that? Or if you're trying to plan ahead, or you're a caregiver for someone who's reaching that stage in life and you're trying to plan ahead, you know, what's the best way to handle that? So I already used the word, but plan, invest, and prevent. So just being mindful of these coming life changes and setting yourself up for success is important. And the way I think about it is, you know, when people who are in the military come to us for dental exams, they always bring a form. Especially if they're going to be deployed, they have to come and see us, and we fill out a form. And it's essentially verifying that we checked everything through. There's no potential thing that's going to cause a problem in the next year to 2 years, because these people are going to be out in the field, they're going to be deployed, they're not going to have access to dental care. And they want someone, you know, they don't want an issue blowing up on that person when it could have been taken care of ahead of time. And, you know, for people who are, you know, at a point in life, or maybe at a point in life in the next 10 years where they might be going into long-term care, or they might be experiencing life changes or health challenges that prevent them from getting care, the best thing to do is just get problems taken care of early. While you're still mobile, while you're still, you know, active, while you're still able to go in for yourself, A, develop good oral hair cavities just at home in terms of how you take care of your teeth, but B, see a dentist regularly, get things addressed, you know, take care of things as finances allow when you can, so that down the road, you're not trying to treat that at a point where it becomes emergency and you're in a situation where it's a lot more difficult to get the care that you need. And something I would say that, and you know, I said down here too, long-term results over short-term cost savings. You know, dental care can be expensive, but you always reach a point where it's necessary. So if you don't address a problem early, you know, if you have a tooth that's kind of hurting you, or maybe has had extensive restorations and a crack, and your dentist is recommending a crown, it almost always becomes an issue at some point. And usually the longer you let it go, the less options you have for fixing it, and usually the more expensive the options become. And something I hear all the time from patients, and it's usually for men when they're about 65 or 70, and women for maybe they're a little bit older, around 80, they say, well, I'm not going to be around much longer, so should we really take care of this? And inevitably, they usually have a solid 10, 15, maybe 20 years left. You know, it's very common these days for people to be living past 90. So yeah, it's just what I tell them. But, you know, like, everybody says that. It's almost never true. And you don't want this to become a painful issue, you know, 10 years down the road when you're less able to deal with it. So that's just a picture of someone who's given up. But the question is it worth it? And the answer is yes. And reasons teeth matter. So like I said, one, increased life expectancy. So people are living a lot longer. They're living actively a lot longer. So that mindset of, oh, I'm just going to kind of ignore this because, you know, it's not a priority, or it shouldn't be a priority. I don't really know if that's valid anymore. There's other reasons too, you know, as other activities become more restricted with age, you know, eating remains definitely a large pleasure in life. And as people lose that ability and lose the ability to chew and lose teeth, you know, it affects their quality of life just when they can't enjoy the foods that they used to. It's also a social activity. And I definitely have patients, who are embarrassed to eat around other people because they've lost teeth or they don't like the way it looks or they're worried their denture is going to fall out. And, it just makes them more cautious and more hesitant to engage in those social activities, which overall, just for sort of holistic health, are a really good thing to do to keep them in a good frame of mind. Better nutrition also equals prolonged health and vitality. So the more variety of foods you're able to eat, the less restricted you are, just the better that is for your overall health. And then finally, just human nature equals, aesthetics always matter. So, I have patients who are 95 years old and missing most of their teeth on top except one or two, and all of their teeth on bottom except three or four, But if you take out that middle one, so there's a gap, it just honestly, it really bothers them. And so they want to fix that, and they don't like the way that looks. And so just thinking a little bit preventatively about that ahead of time is valuable too. Are there any questions at this point about those things we've talked about? Yeah, Mike. Yeah. Yeah. So your question was for those, sometimes people have crowns and those aren't going to decay. And if you have a lot of crowns, essentially, does that kind of mean you're set? Or is there other things you have to look out for? And I would say this, I'm glad you asked that, because crowns are not bulletproof restorations. What I mean by that is you see a crown is a restoration where instead of trying to fill a hole in a tooth or a cavity, you've essentially reshaped the tooth completely from the outside, and you make a covering, an artificial outer tooth, essentially a shell. It covers over everything down to the gum line and cements in place. And it's true that crown is not going to decay. But when we see crowns fail, typically what causes them to fail is one of two things. Either people from brushing too hard or other forces have had gum recession and lost some gum and bone. So that's receded down from the edge of the crown, and now there's exposed root surface, and that can decay. And again, if a tooth is less sensitive, that can usually decay in a way where someone's not aware of it, and that can spread up underneath the crown. It can actually advance quite fast there. So you can get into a situation where, everything underneath that crown is pretty much undermined. It's still there, but one day, boom, it just snaps off. The other thing that can happen if you're not flossing well, usually between the teeth, there's some portion where down below the gum line, there's root surface. That crown doesn't go right down to the bone. So if things are getting trapped between teeth, you can get that same decay against the root again under the edge of the crown, and that can spread up. So it's mindful just to be still diligent about caring for those. And then, yes, any other teeth that aren't crowned, obviously, you can have decay or fracture or other issues. Yeah. So there's a variety of materials. It used to be gold was the main option. Then they started doing sort of meshes of fusing gold porcelain to gold or other metals, and they were trying to keep the porcelain just in areas where it was visible, but still keep chewing forces on metal because the porcelain wasn't very strong. Now they have porcelain strong enough, it's zirconia actually, that it's a ceramic, but it's all white. It's stronger than, as strong as gold or better. Stainless steel crowns are typically used for more temporary crowns. So if it's true stainless steel, those will be preformed and they kind of just snap over the tooth. And those don't seal as well. So they use those in kids a lot when they're going to need to have a crown, but they're going to grow and then the tooth's going to change position. But in terms of, just of all the materials, what's better? I mean, gold is still fantastic. It never corrodes. It's, malleable enough that it's soft. It's not brittle. It's never going to break. It lasts forever. I see people who have gold restorations or even gold fillings, sort of inlays done, from when our practice started in 1956, and they look beautiful still. So gold's fantastic. Most people like porcelain because they want it to look like a tooth. So in dental school, I actually had one guy who I had to do a crown for, and he's probably about 65, and it was on a lower front tooth that was visible. And I asked him what he wanted to do. He got a twinkle in his eye, and he said, "Let's do gold." And I said, "Okay." You have to get everything you do in dental school checked by a professor. So the professor came by, and he said, "Are you sure you want to do gold? That's visible." And the guy was like, "Yeah, let's do gold." And the professor said, "Are you really sure you want to do gold? It's right in front." The guy said, "Yeah, let's do gold." And the professor said, "Okay, I'm going to make you a deal. You go home, you ask your wife about it. If you come back at the next appointment and say, 'Let's do gold,' we'll do gold." So he did that, he came back to the next appointment. I said, what are we going to do for that crown? And he said, we'll do porcelain. So that was a fact. I wanted to do gold for him. I thought it would look good too, but oh well. Yeah. 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 So fluoride, the fluoride you get in your water, the biggest benefit from that actually comes for children and developing teeth, because that gets digested, it gets taken up systemically, it gets secreted in your saliva, and it's present in the tissue as those adult teeth are forming. So it makes it so that when kids' permanent teeth erupt, they're much stronger. And then it also has some topical effect as we drink water too. You know, as a lot of people are drinking filtered water, a lot of people are drinking bottled water, a lot of people aren't getting that exposure. So to have it in toothpaste is good. But I mean, the simplest answer, and again, the question was, if we get fluoride in our water, why do we need it in any other form? Simplest answer is that, you know, the water is systemic and primarily important for developing teeth. And then the fluoride in your toothpaste is topical and meant to be such more of a sort of an application for acute restoration when things have broken down. It is, I mean, it can reach a point, you know, if you have fluoride in your water and your toothpaste, do you also need to be using a fluoride rinse and all that other stuff and getting fluoride treatments every time you see the dentist? Not necessarily, no. But in your toothpaste is good. And I base that just on experience. You know, most people are drinking fluoridated water, but when I see people who are using not fluoridated toothpaste, using fluoridated toothpaste, the people using not fluoridated toothpaste have way more issues, just in terms of decay. Yes. Yeah. 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 Xylitol. Yep. Yeah. Yeah. Yep. Yep. So the question again was, if you have a relative or someone you're caregiving for who is in a situation because of age or other limitations where they're just not brushing, and it's damaging their teeth, you know, what can you do about it? What other adjuncts can you use? And that's just a very difficult problem to solve, because usually whatever limitation is keeping them from brushing or keeping someone from being able to check up on and help them with brushing on a daily basis is also going to keep someone from being able to check up on them and make sure they're using other adjuncts, or it's going to keep the person from doing the same thing. So the short answer is, if someone's just not brushing at all and they're eating and stuff staying on their teeth, it's very difficult to find a good fix for that. Xylitol rinse, I wouldn't recommend. The theory behind xylitol is it's not an artificial sugar. It's a sweetener. It's derived from birch bark. The theory behind how it can help prevent cavities is that bacteria will take it up, the same bacteria that would feed on sugar in your mouth, but they can't digest it. They can't use it for energy. So essentially, if you have a bunch of xylitol in your mouth, these bacteria are going to eat it. Essentially, they'll starve and they'll die off. That's protecting your teeth. The difficulty with that is the studies that actually prove that to be true have been very limited. The ones that have shown their success have also shown that it doesn't work at all. I think the best evidence, which is still pretty weak, is that it might be effective in children, but not in adults. And in the studies that showed any success, it was kids like chewing xylitol gum, and they were chewing it all day long, like constantly. So using it as a rinse, I think, would not be good. I think a much better thing, if you could get someone to do it and make sure they were doing it, would just be to have them use a fluoride rinse and just maybe try to hold that in their mouth for 3, 4, 5 minutes and spit while they're watching TV or something like that. If you thought you could get them to do that and count on the fact that they were doing that. Again, it's a question of kind of mobility, caregiving, is someone there to help them do it. Sometimes it's just good if they can see the dentist instead of every 6 months, every 3 months. So they're just they're not taking care of it at home, but maybe they're going to see the dentist. They're getting the teeth cleaned more frequently. They're keeping a sharper eye on things. So if they do get decay, it can be addressed really quickly. And also maybe getting fluoride varnishes there. Another thing that can be beneficial is, if they're brushing not all the time, but sometimes, looking into maybe getting them a prescription for that toothpaste, and then brushing with toothpaste and spitting without rinsing can be very effective too. But that just does, I had to do that. I was one of those teenagers who was not mature enough to have braces. And so I had to use that toothpaste after I got my braces off. So you rinse with it, you brush with it, you spit, you don't rinse. And it's a really weird feeling to just go about your day or go to bed with that toothpastey feel all over your mouth. But it just keeps that fluoride in contact with the damaged tooth surface, and it can really be effective. So, yeah. Uh, that's true. Some people do feel that way. Absolutely. So the people who feel that way, typically the fear is based on some evidence and uh, worries that it would be more systemic fluoride, exposure to systemic fluoride at high levels when you're young has some association with bone cancer. That's kind of the I think the origin of that fear and that worry about fluoride. And I think from that, it just kind of, bleeds into the general, well, we don't want anything artificial. We don't want to rely on, you know, unnatural chemicals or chemicals that aren't normally part of our diet in that concentration. What I can say about it, and I don't always have the facts of the specific studies that refute a claim like that at my fingertips, because it's the kind of thing that comes up with a patient every few years. Okay, you dig it up, you look into it, but you don't necessarily retain that. Fluoride is naturally found in water, and that's how it sort of became an element that they added to community water because, epidemiologists noticed that there were certain areas of the country where kids got way less cavities than other areas of the country where they didn't. And when they tested the water, fluoride it is a naturally occurring element. It's in various water sources at various concentrations. And so the amount that they add to drinking water and public water, it is at a level that's below what's found naturally occurring in some other places. And I don't think that they've ever made an association between those naturally occurring varieties and increased incidence of adverse health effects. I'm not 100% positive about that. But setting that aside, fluoride in toothpaste is topical. So you're using it, you're spitting, the amounts, and I've seen this too, where dentists have calculated, the amount you put on toothpaste with the concentration of fluoride, how much below FDA safe recommended levels would that be even if you were swallowing everything? And it's tiny. So it's, the fact that in toothpaste and rinses, it's topical, it's going in your mouth, you're spitting it out, you're rinsing afterwards. It's hard for me to imagine a way in which that would have a systemic effect that posed any risk at all. Yeah. Yeah. There's a million. Oh, yeah. 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 So the question is, when you go to shop for toothpaste, there's hundreds of brands, and a lot of them are whitening toothpaste these days. Are those okay to use regularly? And the answer, I guess, for me would be that depends on the patient. So the whitening toothpastes have a very, very low concentration of a bleaching agent in them, which is meant to bleach out stains in teeth. There's plenty of people who otherwise have healthy oral environment and teeth that can use those long-term, no ill effect at all, don't notice anything. Other people will use them and they find they make their teeth very sensitive. And I would say in most situations when people have healthy teeth with good nerves and, kind of thing where they get a cavity, they can feel it, something's wrong, they'll know if that's hurting them. They'll complain that, oh, my teeth are suddenly very sensitive to cold, very sensitive to water, and then you just say, step back on that. In a situation where maybe someone had, again, as we age, our teeth become less sensitive, and a lot of recession and exposed root surfaces, it's possible that those could be damaging. And if you've never seen a dentist, I would maybe advise caution, but it's the kind of thing, if it's causing a problem, a dentist would see and be able to notice, but typically they don't. And the biggest complaint I hear with those is just it's making people's teeth sensitive. So, yeah. Did you have a question? Yeah. 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 Yep. Deep as they were. Yeah. 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 Yep. It will. Yep. Yeah. And that's really good. Yep. And the question was, I think, are water picks an effective solution for cleaning between teeth, especially compared to floss for people where it's difficult to floss? And yes, and in flossing more than brushing, I would say probably, especially as people face agility problems as they age, is very difficult. But it's difficult for a lot of people too, just because they have tight contacts. It's hard to get in there. Um, if you can floss, flossing I think is the best option for cleaning between teeth. I think it's better than the water picks, but water picks are much, much better than not flossing and not using a water pick. So they do a fairly good job of cleaning between teeth, and you're taking out a lot of debris that's trapped there that can cause trouble. So I think they're a fantastic option in a situation like that. Yeah, absolutely. Yeah. So for people who grow up, yeah, I would say suppose. So for people who grow up in, the country with maybe well water without access to fluoride, we'll have a test kit where they can test the fluoride concentrations in their well water. And like I said, it can be naturally occurring if the levels are good, that's fine. But there are fluoride tablets you can give to crush up if, kids are in a situation where they don't have access to that. So yeah, probably she was doing that. Yeah. All right. I want to talk a little bit about options for replacing teeth. If any of you guys are really interested in this, let me know. There's also some things I want to talk about with gum disease and Alzheimer's at the end that I want to have time for. So we'll go through these quickly. Dental implants are an option for replacing missing teeth. They're essentially an artificial root. So what you see here is natural teeth above the gum line with their roots in the bone. A dental implant really has three components. It's an artificial titanium screw. So you actually drill a series of progressively larger holes right into the jawbone, and then you insert this screw. You usually leave it covered over with a cap at the gum line for about 3 or 4 months as the bone heals around it. But at that point, you can put a post into it, which sticks up above the gum line, and then a crown can go over that. And the advantages of those for replacing a missing tooth is that they're the most like a natural tooth of anything you can get. So you can floss on either side of them normally. You don't have to affect any teeth on either side of them, like a bridge would, where in a bridge you would put a crown on this tooth and on this tooth, and supporting in the middle would be a false tooth or a denture. But those have become very, very common in the last 10 to 15 years. A lot of just general dentist office replacing them, where you used to have to go to a specialist. They're still expensive, but the cost has come down quite a bit too. Partial dentures are just a situation where if you're missing multiple teeth, can kind of create a metal framework that latches on to supporting teeth and then has artificial teeth in the gaps. Those are really good options for replacing, a situation where someone has multiple missing teeth at once. They do come in and out. There's complete dentures, which just, have an acrylic sort of mold that fits over the arch of bone and gum tissue that's there and supports fake teeth. Something that's really nice and can be nice is in situations where people have ill-fitting dentures, you can use these attachments to secure a denture. And this can be done in one of two ways. If someone has no natural teeth left, you can put implants into the jawbone, and they'll have these little gold caps that stick up above the gum line. It's kind of like a ball and socket, like a trailer hitch. And then you'll create depressions, I should say, in the inner surface of the denture that fits over those, and they snap in. Literally, you push down on the denture and you hear a little click. Particularly for lower dentures, where that ridge of bone is thinner and you're having to deal with the floor of the mouth, which is soft, and the muscles of the tongue, which move. That can be a really great way to secure a denture. Another way this can work is instead of implants, if someone has 2 or 3 remaining teeth, usually the canines, the sharp teeth that have really strong roots, you can do root canals on those teeth. So you take out the nerve, so they can't get infected, and you can actually sort of cut those off at the gum line, a little bit above, and actually put caps, cement caps over those teeth that have these attachments that the denture can snap into. So those have been really interesting. Something that's become more common too in the last 5 or 6 years are these what's called all-on-4 dentures. So this is a situation where a dentist would put in 4 implants, say in the upper jaw, and make a denture that has an acrylic ridge, but it wouldn't fit over the whole roof of the mouth. So it would just be a line of acrylic that went right on top of the gum ridge. And it has holes in the back side of it that actually screw into those implants. That becomes a permanent restoration. So you can replace all the teeth in an arch. You can screw them in. They're stable. They're fixed. You don't have to take them in and out at night. For someone who has trouble caring for their own teeth, it can be a fantastic option. Our newest dentist, Dr. Gretchen Ostaba, just did a case like this for an elderly gentleman a few months ago. Downside of that is it costs about as much as a new pickup truck. So it is not cheap at all. So, you know, for someone who has the means and that's really important to them, it's a great option. But as things currently stand, it's not in reach for a lot of people. Last thing I wanted to talk about was kind of systemic health related to dental health. And so this is less about the teeth, but it's more about the gum tissue. And so all of you may or may not have heard of periodontal disease, but there's sort of 2 things we're looking at. We're looking at tooth health when you come into the dentist, and we're also looking at gum health. Anytime we eat anything, just a sandwich, no matter what, those bacteria in our mouth are, you know, producing byproducts. They're making plaque. And plaque is basically just a sticky film, and it's composed of kind of dead cells, bacteria byproducts. But it's the kind of thing you can brush off, you can floss off. If plaque stays there long enough without being removed, it mineralizes. So minerals in your saliva attach to it, and it forms almost like a concrete, like a really hard, chalky substance stuck to the teeth and to the roots, and usually below the gum line, and it drives inflammation. And as that happens, the gums become inflamed. You actually lose attachment of the gums to the tooth root, and that bacteria and then the plaque and then the tartar can go deeper. It drives more inflammation. The gums detach more. Eventually, you start to destroy some of the bone. So on your left side of the picture here, you'd be seeing healthy gum tissue. So the bone here with the gum over it, all these little ligaments attaching the gum to the tooth root. Over here, you see periodontal disease, where you have this calculus, this tartar attached to the tooth, inflamed gums, loss of those ligaments attaching it to the bone, and ultimately loss of bone itself. Long term, that can lead to tooth loss. The teeth can just become loose. I think more importantly, a big issue with this is they found in the last 10 years really that there's a huge systemic implications from untreated periodontal disease. And one way to think about this is, you know, if you have gum tissue that's really inflamed, you see this all the time, you know, people come in and they accuse us of, you know, jabbing our probes or our measuring sticks into their gums, and they think we're horrible people. Honestly, a lot of times we're just lightly touching it, and you lightly touch that gum tissue and it'll just start bleeding and it won't stop. Someone, enterprising dental student or grad student, actually measured the surface area of all the gum tissue inside and out surrounding the teeth. And if you add that up, it comes out to be about the same surface area as your palm for any given individual. So if you think about walking around in daily life with a palm that was just inflamed and anywhere on your palm you touched and it just started bleeding, I think it'd be obvious to you how bad that is for your health. So it's a big systemic burden of just inflammation to be dealing with. But the other issue is that in that environment with that inflammation, those deep pockets, conditions change and types of bacteria that normally are very minimal in your mouth suddenly start to thrive. And one of the biggest ones is called Porphyromonas gingivalis, just P. gingivalis. And this is, you know, an artist's rendering of that there. And you see, you know, kind of gum tissue and then exposed bone. What P. gingivalis does is it feeds on destroyed human tissue. And in order to do that, it actually releases chemical signals that turn your immune system on and drive an inflammatory response. So your immune cells come in and they just start shooting things up and breaking down your own tissue. And it also releases chemical signals that kind of protect it from that same attack. And then it just feeds on all the debris. So this is going on just in gum tissue, and it's why it's inflamed. It's why it's bleeding easily. But when that happens, the vessel walls in your gum tissue become compromised. That same bacteria can get into your vessel walls and spread to other areas of your body. They didn't know this, more than I'd say 10, 8 years ago, because you can't actually culture that bacteria internally from somebody. So it was only when people developed the ability to sort of do DNA sequencing that they could look in diseased tissue, so sort of in artery walls of people who had heart disease and the brains of people who had Alzheimer's, and they could find the DNA markers that showed them this bacteria, this specific bacteria, P. gingivalis, is present in those areas, and it's doing the same things. So just driving low-level inflammation, causing your body to attack itself, and kind of feeding on that. So there's a correlation between people with uncontrolled periodontal disease and heart disease and diabetes and Alzheimer's. And there's been, Alzheimer's, people have been known about Alzheimer's since, the 80s, I think. I'm not sure when it was kind of first classified as a disease. The driving theory behind what causes it has been the accumulation of what they call these amyloid plaques. So they look at the brains of people who had severe dementia or severe Alzheimer's, and they find that they're covered in these protein plaques. And they just assumed always essentially that those protein plaques were what was causing the memory loss and the other symptoms of dementia. And so almost all of the therapies developed or the money plowed into research for Alzheimer's were focused on things that would disrupt the formation of those proteins or the accumulation of those proteins. In the last few years, they've done studies, and there's a few groups that have done studies that have found P. gingivalis in the brains of people with Alzheimer's in much higher concentrations than in people with Alzheimer's. And some of the toxic byproducts of that this bacteria makes in the brains of people with Alzheimer's, and correlations between those byproducts and different of those plaques and those things that are building up in the brains of people with Alzheimer's. And they've done studies in mice that have been genetically engineered to be prone to Alzheimer's, where they've then given them gum disease by essentially, injecting a bunch of this bacteria into their gums. And those mice have gone on to develop Alzheimer's. They've given them drugs that have blocked some of the actions of the toxic byproducts of this bacteria, and the Alzheimer's symptoms have reduced. And it's undoubtedly a very complex kind of multifactorial disease, but I do think it's interesting that there is evidence lately that this kind of uncontrolled gum disease over the long term can cause this bacterial action elsewhere in your body and could be a contributing factor to some of these things. So it's something I just really strongly encourage people to come see me today when we see signs of gum disease, when we see signs of easily bleeding gums, that it's not something that should be, sort of ignored, something we need to address. Yeah. So there, the question was, could there be a relationship between this and an abscess or a sepsis in the bloodstream? So they have known that bacteria from the oral cavity can get into the bloodstream and cause other problems. A big one is in artificial hips and knees and joints. It used to be that they recommended anybody getting a dental procedure who had an artificial hip or knee or joint take a big dose of antibiotics before they had that procedure. They've backed away from that recommendation recently, and the reason is, there's evidence that people are exposed to that risk so much just in daily life, like you eat a chip and it breaks and you cut yourself a little bit in your gum tissue, or you're brushing too hard, or you have, most people have some degree of gingivitis at least, sort of early stage gum disease, that it's not dental procedures themselves that are putting people at such risk. But so yeah, there can be a correlation between that. An abscess I typically think of as a very acute inflammation around a tooth. That's usually due to decay and bacteria that's actually gotten internally into the root system of a tooth. Yeah. 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 Yep. Yeah. 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 And I guess that's hard to say, honestly. And it is a concern, and it does happen where someone has an abscessed tooth and it's left untreated for a very long time, and it can become systemic. Usually in that situation, though, what you see is a progression where they had the abscessed tooth, there was no swelling around it in the soft tissue, it was just something you saw on an x-ray, and then they started to have really severe pain, and then kind of their whole cheek and their jaw and their face became swollen, and then it goes systemic. Could it be that, it was there, you could see it on the x-ray, they wouldn't have any of those localized problems, but it went septic? I guess I don't know, but I would kind of expect more localized explosion first and then systemic progression. Yeah. Any other questions? Yeah. So a root canal. Let me find a picture that will help me explain it. So this tooth right here has had a root canal. This tooth has not. And in a root canal, and then maybe it's easiest to look at this, young tooth because the pulp chamber is so big. What happens is because of decay or a crack or something else, bacteria gets into the inside of the tooth, this hollow chamber and the chewing portion, and then down through the roots where the nerve and the blood vessels and the soft tissue is. And usually the nerve will go dead, or it'll be on its way to going dead. If that progresses long enough, that bacteria can come out the tip of the roots and it starts spreading in the bone. And in that instance, you would see a big dark area just around the tip of this root, like a big bubble in the bone, where the bone's being destroyed because of that infection. The difficulty is when that happens, the blood supply into the tooth essentially gets cut off. And anything your own body would use to fight infection, your immune system, or any antibiotics we would give you to fight infection, they all get carried through the blood. So they can get to that area around the tip of the root and the bone, and they can clear up the infection there. Person might start feeling better, but as soon as the antibiotics are a week later, it just comes roaring back because nothing ever got into the inside of the tooth where the bacteria was. So in a root canal, what you're doing is you're making a hole through the top of the tooth till you can see into this hollow space. You can actually see these little openings leading down into the roots. And then you're just using files to mechanically clean out all that infected tissue, all that dead nerve tissue and debris. You're kind of widening that area somewhat, disinfecting it chemically, and then you seal up that entire system internally with kind of a rubber-like material, just so there's nowhere for bacteria to harbor. And once you've done that, usually the tooth is just fine. Things will heal up. And as you can see, you see pretty good solid speckled bone all around the tips of these roots. Probably before this root canal was done, you would see big, dark, infected areas. Once the root canal is done, that can heal up. Well, thank you for having me very much. This was fun, and I like talking to people your age instead of teenagers, because teenagers don't ask any questions. They just stare at you, and they grunt, even in the dental chair.